Good morning. This is Dr. McDaniel at GYN Corner. I'm a board certified obstetrician gynecologist in New York City, and I'm bringing to you all things health related for women. Thank you for joining me at the corner today. This is the look. I have the masked bandit look, which is what I call this. We still have the coronavirus lockdown here in New Jersey and New York. I'm on the train, and the trains are all mandating still that we all keep the mask on. So I have the masked bandit, the train robber look for the presentation. We're getting a little busier at the office. I still have the shortened hours at the office because one, the building is closing earlier, so we can't keep our late hours even if we wanted to, and two, because the patients aren't coming in the evening anymore. Most people are working from home, so we are doing predominantly the virtual visits, and then we'll have a few patients come in for either routine annual or for pain or infection or something. So we just have 8 hours, and they're limited hours. So with our limited hours, the virtual visits are really getting stacked one after the other. So I'm trying to multitask by doing the presentation today on the train, and then when I get to the office, it's just it's off to the races because we're starting out straight away at 15 minutes. And then I have virtual visits, so one after the other, and I think we have 2 procedures today, so it's going to be busy. Uncharacteristically, since the lockdown, very busy day. Trust everyone's doing well. Apparently most of the country is opened up, but here in the tri-state area, New Jersey and New York, they're still hanging on to the quarantine for most people. So things are still fairly quiet in New York City. I'm going into New York still. Throughout the whole pandemic, I've been going in 3 days a week. So Mondays, Wednesdays, and Thursdays, and still fairly quiet. It's not a lot of people in the city. It's nice because it's not crowded, dealing with masses, but then it's a little strange because I've been living in New York since '93, so used to tons of people, used to the cheek and jowl scenario. So we'll see. Hopefully we'll open up soon and things will get back to normal so that we can people can start getting into the routine and the economy can brighten up. A lot of businesses have closed down in Manhattan because people are working from home. They're not even ordering delivery or takeout from the restaurants in the area because they're far away from it. So a lot of the places I think have closed down and they're not going to reopen, so it's a little unfortunate. But let's see, today is part 4 on pelvic pain. So please refer to the previous presentations on pelvic pain because the details are in those presentations. I'll just give the gloss over. So the pelvic pain is a common complaint that I get in the office on a regular day. Probably 1 out of every 7 or 8 patients will complain of pelvic pain. And the first thing I do is I get the story from them. I get the history because the question is it really pelvic pain? A lot of times people say they're having pelvic pain. It's not actually the pelvis, it's the abdomen, or it's more really their what we call the flanks, so the lower sides are almost towards the back. So one is or it's vaginal vulvar pain, which medically we don't consider that pelvic pain. We consider it vaginal or vulvar pain. It's a little different. The sources, the etiology of the pain is different. So I get the story to determine if it's really pelvic pain and then what the nature of the pain is. Is it sharp, stabbing like a knife? Is it dull, achy, like they've been punched in the arm? Is it a burning sensation? Is it a heavy pressure, like they have a big bowling ball in their belly? Or is it a needles and pricks and needles and pins, or a stinging sensation? So lots of different types of presentations give us an idea of the type of pain that someone that is having, and it gives us an idea of what the potential source of it is. And the nature of the pain, when did it start? How long have they had it? Is it constant? Is it coming and going, waxing and waning? What kind of things make it worse? What kind of things make it better? And if the pain looks like it is a vaginal source of pain, I will always do a vaginal pelvic exam. If they say it's like a heavy pressure, or their belly's hard, or their belly's really tender to the touch, or especially if they have a fever, then I will always do a pelvic pain. But other than that, if the pain is with the menstrual cycle only, I never do an exam. Or sometimes people come in and the pain was like a week or two ago. They just want to get an idea of what it was. Then I don't do a pelvic exam. It's no longer there. And if it's with the menstrual cycle, it's usually hormonally induced pain. That's the most common. So I don't do a pelvic exam because we'll eventually get an ultrasound. But for the other scenarios, I will always do a pelvic exam. If it's vaginal vulvar pain, or if it's only pain with intercourse, I do the exam because sometimes it's due to a laceration, a cut, an abrasion, a skid mark, or sometimes it's a herpes outbreak and the patient just wasn't aware. Occasionally it's from a yeast or a fungal infection, and there's a lot of skin irritation, inflammation, or a rash or sores that she wasn't aware of. If there's any kind of bleeding with the pain, sometimes people have bleeding. If the bleeding is only with intercourse, then I'll definitely do an exam, even if the pain isn't just with intercourse. So the exam will give us information if it's vulvar, vaginal, or sometimes I'll do the exam if she says like heavy pressure, or the belly's hard, or the belly's exquisitely tender. I'll do exam because there may be a mass, a cyst, a fluid collection, or a fibroid uterus. So we get a heads up on what the potential source is and how to address it and treat it. Secondly, we always send urine for cultures because oftentimes the pain will be from an infection. And as I stated in more detail in previous presentations, it could be from an atypical or asymptomatic bladder infection, or chlamydia, gonorrhea, because those can cause a pelvic infection. And only 10% of the time will someone have pain associated with the pelvic infection, but we always send the urine just to confirm. And occasionally someone will have pain and a pelvic infection due to pain from douching around mid-cycle when they're ovulating, or too close to their menstrual cycle, or from having unprotected intercourse too close to their menstrual cycle, because blood increases bacteria, and then the swooshing of body fluids with ejaculation, or if they're douching, will push that bacterial-laden blood up into the uterus. That will definitely cause an infection. After that evaluation with the history, the exam, cultures to see if it's from an infection, if the pain persists after another menstrual cycle. So I always give the patient one full menstrual cycle. If the pain persists after the menstrual cycle, then we get an ultrasound. I'll do a sonogram, I'll do an ultrasound to see if there's a mass, a fluid collection, a growth, any kind of physical evaluation that could explain the source of her pain. If everything comes back normally and the pain really is associated just with the menstrual cycle, then we say it's hormonal pain, and the recommendation is always to trial of birth control pills to suppress ovulation, suppress the hormones that should suppress the pain. If it's not just with the menstrual cycle, it's random, there's no rhyme or reason, there isn't a pattern to it, then I will always recommend that she seek additional evaluation with other specialists. So the uterus, the ovaries, and the tubes, cervix, they're not the only organs in the pelvis. So other organs in the pelvis are, of course, the bladder. So that would be a urologist, along with the ureters. Could be kidney stones or crystals or diverticulum, or inflammatory changes in the bladder. Or could be intestinal. Even if it's not related to dietary changes or bowel habit changes, it could still be intestinal. So that would be a GI doctor, gastroenterologist, or it could be musculoskeletal. So in that case, they would see their primary care doctor first, if it's musculoskeletal, and then potentially they'd see maybe an orthopedic surgeon or a neurologist depending on the source, or even a rheumatologist if it's arthritic. So there's a wide variety of potential sources for true pelvic pain. It's not just GYN, but GYN we're always going to be the go-to, the first ones people will see, because that's the biggest one to evaluate and see if it is or is not a reproductive source of pain. So I hope that's been helpful information on the evaluation of pelvic pain. Thank you for joining me at GYN Corner. Please hit those likes, subscribes, and follow buttons. Leave comments or questions if you have any information that you'd like to get from me that I didn't already provide. Have a great rest of your day. Bye.